Okay, we'll go ahead and get started today. It's now 2:30. I want to thank everyone for joining us today. My name is Nikki Forbingor, and I'll be the moderator today. I will turn it over to Director Jeppesen.
Still remains twice that of the target of 5%. The number of new cases remains past week, we remained at high but declining daily average census numbers, with 439 COVID-19 patients on average in the hospital last week, 139 COVID-19 patients on average in the ICU, and 75 COVID-19 patients on average on ventilators. Thank you, Nikki, for sharing that chart. I appreciate that. Well, when will we exit crisis standards of care is a question many people have. One of the reasons that this question is on people's minds is due to the delayed surgeries and other treatments. For those of you who are experiencing the delay in medical treatment, my heart goes out to you. I can only imagine how difficult that delay must be. The short answer is that Idaho will be able to exit crisis standards of care when the surge of patients being driven by COVID-19 no longer exceeds the healthcare resources available. Here are a few examples of things that will let us know we can exit crisis standards of care. Non-clinical or non-traditional spaces are no longer being used to care for patients. Patients who should be admitted are no longer being boarded in the ER. Instead of large hospitals transferring patients to small hospitals, we can return to normal where small hospitals can transfer critical care patients to large hospitals. At least some postponed surgeries and medical treatments can continue, and we actually are starting to see this happen in some hospitals across the state. The staffing to patient ratios can return to normal, and the trend of new cases and hospitalizations is declining. To exit crisis standards of care, we all need to continue to do our part. Now that a COVID-19 vaccine is available for children ages 5 to 11, it's a good time to not only get children those ages vaccinated, but also to get the entire family vaccinated, or get a booster shot for those who are eligible. And with that, I will hand it over to Dr. Hahn.
Thank you. Thank you so much. I'm sorry to have to report today, and as some of you may have seen in our press release that we just released at 2 o'clock, that we are confirming the first death in a child today. Please see our press release for more information. The child was an infant, died in October, and protective privacy of that family, we will not be releasing more specific details about the death. However, we do want to talk today about preventive measures in families. The situation highlights the seriousness of COVID-19, even among younger people, and the impact it can have on families. As you all know, COVID-19 vaccination is now recommended for people age 5 and above, but for those under 5, there is no vaccine approved. The vaccine recommendation includes women who are planning on becoming pregnant, women who are already pregnant, and men and women who have children at home. All of these folks can also receive a booster shot if they're eligible in one of the eligibility groups. There is no evidence that the vaccination causes infertility or among those getting vaccinated. In fact, there's growing body of evidence and studies that are showing that it does not. Getting a vaccine can protect parents and prospective parents from severe illness from COVID, and also can help protect babies. I wanted to provide some data from our Bureau of Vital Records and Health Statistics, I'll just kind of reinforcing some of the serious health impacts that we've had reported to us. So as far as maternal mortality, we had none reported in 2020, but so far in 2021, we've had 4 COVID-related deaths in women who had been pregnant within a year before their death. So some of those women left behind young children. We had no stillbirths reported in 2020 due to COVID-19, but there have been 2 stillborn infants reported in 2021 in which COVID-19 or recent COVID infection was listed as a cause or underlying cause on the death certificate. We've also had deaths among women in childbearing years, which we usually consider age 15 to 44. There were 6 deaths in that age group among women in 2020 and 37 deaths among women in that age group in 2021. And these deaths remind us how serious COVID can be, even in younger populations and for young families. I'd like to turn now to some quick vaccine updates. First of all, we're very glad that almost 80% of our seniors age 65 and above are now fully vaccinated against COVID-19. This is a bit below, but not that far below the national average of 85.6%. So we're really happy that our seniors are getting vaccinated. And we do urge those that are eligible for a booster shot to get that now before the holidays when there's more travel, there's more family around. And we are excited to see that we see the number of 65 and older that got their booster inching up. And as of today, almost 40%, 39.8% of Idahoans age 65 and older are estimated now to have received a booster dose. So we find that really encouraging that folks are getting their boosters, and we urge others to consider doing so. We are concerned, however, about the vaccination rate in our younger age groups. Only 52%, or barely over half, of adults under age 65 are fully immunized. And among our adolescents, it's even lower. 38% of our 16 to 17-year-olds and only 32% of our 12 to 15-year-olds are currently fully vaccinated. Lastly, I'll just mention quickly, among young people age 5 to 11, so far, we are hearing that parents are seeking vaccine for their children are able to get vaccination appointments. Some places are walk-in, some places are appointment only. There have been some really great media stories on this, and we appreciate everyone helping to get that information out. We've had no reports of problems so far, and no reports of any severe reactions in that age group. Again, we know it's just starting to ramp up. We do know already that 2,257 kids in that age group, 5 to 11, have already been reported to us as having received vaccines. We hope that all continues to go well. And with that, I'm going to turn it over to Dr. Guzman.
Perfect. Well, thank you and good afternoon. I'd like to take a moment to thank Director Jeppesen and his team for allowing me to be here to talk to you about pregnancy in the context of COVID-19. Excuse me. We're currently seeing our world turned upside down, all as a result of a novel virus which has devastated many aspects of our lives, has transformed our communities like very few events in the history of humankind have before. A woman's body undergoes many changes to be able to adapt to a growing baby inside a mother. Some of these changes, unfortunately, make a woman more prone to certain medical conditions. It's a well-known fact that most, if not all, respiratory infectious disorders tend to manifest more severely in a pregnant woman than in a non-pregnant one. COVID-19 is no exception. To be more specific, in a pregnant woman, the risk of getting admitted to the intensive care unit, the need for mechanical ventilation, as well as the risk of death are all increased when compared to a non-pregnant individual. From a personal experience, I have seen several of my patients suffer the consequences of COVID-19. I've had patients either lose their pregnancies to COVID. I've had patients sick enough to either go into premature labor on their own, or as a consequence had to be induced before their due date to allow the teams caring for the mother-baby couplet to deliver the baby and now focus on saving mother. Babies that have spent weeks in the neonatal intensive care unit as a consequence. Babies that, although I hope they do, may not be able to reach their full potential. I've seen the parents of these babies fret about the health of their newborns. And these are only my personal experiences. They're people from our communities, and I'm pretty sure that other providers in the Treasure Valley have their own horrific experiences to tell as well. Now, to talk about the vaccine, the current recommendations by the American College of Obstetrics and Gynecology, the Society for Maternal Fetal Medicine, as well as the Centers for Disease Control, enthusiastically recommend vaccination of pregnant, recently pregnant, as well as lactating mothers. The technology that drives some of these vaccines is nothing short of amazing, especially mRNA, which carries into our cells the code for our bodies to produce the coronavirus spike protein and provide our immune system with instructions on how to fight COVID. mRNA does not enter the nucleus, and hence it does not alter a patient's DNA. The technology is not new, it's been around for years, and it allowed scientists to quickly and safely produce us with a vaccine. The safety and efficacy profile of the vaccine in pregnant patients is very similar to non-pregnant ones. The risk of a serious adverse event is very small. As an example, the data that I am familiar with shows that the risk of an anaphylactic reaction is only approximately 1 per 200,000 cases. Data from across the United States, as well from the rest of the world, does not indicate any evidence of harmful effects. The vaccine, the COVID-19 vaccine, has now been around for over a year, and tens of thousands of doses in pregnant patients have given us insight into how safe it truly is. The V-Safe program registry data shows that the background rate of major pregnancy-related complications is very similar in the vaccinated community as well as in the unvaccinated one. We have not seen an increase in pregnancy complications, and certainly we've not seen an increase in pregnancy losses in the vaccinated population. Again, the growing body of data is only testament to the safety profile of the vaccine. But the vaccine's not only safe, it is also very effective. Let me explain what I think effective means. Think of a vaccine as a seatbelt. Seatbelts do not prevent car accidents, but they keep you alive if you do get into one. Likewise, you can still get COVID-19 after being vaccinated, but if you do get COVID-19, you are very, very much likely to survive if you do. To think and reflect back on my patients who had a poor outcome as a consequence of a COVID-19 infection, whose families have been devastated as a result, to the countless people who have either died or will now potentially have long-term health effects as a consequence, well, pregnant women and newborns are no exceptions. It is very unfortunate that although we live in an era of information, disinformation abounds, and that many of these situations could have very easily been prevented by receiving the vaccine. And truly, I'm only recommending what I'm doing for my own family. When my pregnant sister-in-law approached me and asked me whether she should get the vaccine, I did so. I recommended that she do. She just delivered a healthy baby boy in Texas, and both are doing very well. I really want to take a few minutes and reassure women who are either pregnant or considering pregnancy that the vaccine is not only safe, but also very effective, and they do help both mom and baby. So with that, thank you so much for your time.
Okay, thank you, Dr. Guzman. We will now take media questions. Most of you know the drill so far, but I'll just remind everyone to please raise your hand in WebEx or type your question into the chat area. When I say your name, you can go ahead and unmute yourself and then announce your name and media outlet before asking your question. And then remember to clear your hand when you're done. Let's see, it looks like our first question is going to come from Melissa Davlin.
Thanks, Nikki. Melissa Davlin with Idaho Public Television. I'm not sure who this question would be for, but understanding that death isn't the only adverse outcome for children and young people, is the state keeping track of long-term illnesses or severe infections in children? I know that one Nampa toddler recently experienced kidney failure, or sorry, liver failure. Are there any other ways to track these adverse outcomes?
Thanks, Melissa. I'm doing my quarterbacking again this week. I'm going to actually ask Dr.
So that's one. Regarding just, maybe after acute infection, some of that, what's called long COVID outcomes in children, we are not tracking at the state level, but there are some special studies that are ongoing in the United States, and we're really keeping track of those data and making sure that we're up on what is being seen in those pediatric populations in those special studies.
Thanks, Dr. Turner. And just to make sure that I have that correctly, the state isn't tracking long COVID in anybody, right? Not just children?
Yeah, that's exactly right, Melissa. That's correct. One of the things that we collect the data we need to collect in order to take public health action. And so while acute infection is something public health practitioners can respond to and determine exposure, do contact tracing, but tracking people over the long term, just to have that information is not something we typically do as a routine census, tracking everybody. So that's why those special studies are so important.
Thank you.
Okay, our next question is going to come from Andrew Bartline.
Andrew Bartline at Channel 7. We just got that press release about the first infant in Idaho to die of COVID. I know it says that there's not a lot of information available, trying to protect the identity of the grieving family. But my past conversations with Dr. Guzman led me to believe that it's really uncommon for COVID to be passed down from mother to infant through birth. Do we know if that was the case in this scenario?
Thanks, Andrew, for the question. I'm going to let Dr. Hahn start and then ask Dr. Guzman if he has any follow-on remarks regarding that question.
Yeah, thank you for that question. Indeed, on the review of the literature, I'd agree. It seems to be an unusual circumstance, and I can't speak specifically to what happened here in this particular case. I don't know if Dr. Guzman has something he might want to just say about mother to infant.
Oh, well, absolutely. I think that it's very important to continue to take all preventative healthcare measures, social distancing, face mask, hand washing, and certainly the vaccine is a very important tool to prevent or minimize events like these. I do think it's important that all pregnant women talk to their own doctors and understand what their local situation is. And my understanding is the majority of hospitals are testing on admission pregnant women. And if positive, we certainly emphasize even more so all the precautions they can take to, again, minimize really, really sad cases like this.
And then a quick follow-up, sort of on a different track, reinfection rates in Idaho, is that being tracked at all? Do we have any idea about what natural immunity efficacy looks like in terms of, maybe that runs out and when you're prone to be reinfected?
Yeah. Dr. Hahn, do you want to?
Yeah, I'll start, and Dr. Turner might have something to add. First of all, kind of like Dr. Turner alluded to previously with our data systems and our work, we are not powered, if you will, with our data to completely address all those questions, but we have lots of studies and information from around the country and around the world about that. We do know that that some people do have. In fact, CDC has come out and said maybe 3 months, maybe 6 months of pretty good protection. But that vaccination is still recommended because there's no way to know for sure who those folks are that are going to be protected and for how long. However, the current recommendation is that probably for 90 days, if somebody wanted to delay, they are probably pretty well protected, at least for that long. And I'll let Dr. Turner talk about our data and what we have there.
Thanks, Dr. Hahn. We do have people who have been infected more than once in our data system. However, you can well imagine that there's a lot of quality work that has to be done. So we are working right now on going through all of the almost 300,000 cases and looking at those people who have been reported twice, sometimes 3 times, and making sure that the statistics that we can put out publicly are spot on. So that process is ongoing right now. So it's a great question because it's very timely. All right, thanks, Dr. Turner. Our next question is going to come from Audrey Dutton.
Hello, Audrey Dutton from the Idaho Capital Sun. I'm not sure who this question is for, perhaps Dr. Hahn. Is there any solid research on the rates of myocarditis or long COVID or any kind of adverse health outcome generally after infection for younger children? The data I've seen, there's a CDC study that found a 16-fold higher rate for post-infection myocarditis compared with the vaccine, but that study and all the other research that I've seen seems to only look at adolescents and older. And now that we've got the vaccine open for 5 to 11, I think parents are trying to figure out what the risk benefit is there for their individual children. So do we know what the bad outcomes are for children in that age group?
Yeah, I can start, and I don't know if Dr. Guzman has anything he'd like to say. I'll just make a general comment. In general, myocarditis is more common in adolescents. It appears to have something to do with puberty or hormone changes, or whatever. But you find, as you know, before the COVID days, myocarditis was sometimes there's no cause found, but when it is found, it is often thought to be precipitated by a viral infection. So a viral infection that might, like influenza, can cause myocarditis. So viral infections that go around, respiratory viruses, other viruses, can cause myocarditis. And for some reason, that age group seems to be vulnerable. I think that the reason you don't find a lot of good data in those younger populations, it's a very, very rare occurrence. So it's very hard to compare a very, very rare occurrence with something that is brand new and, is obviously just starting to get rolled out. Obviously, people are very, very interested in that. We are following that. I think I mentioned in my remarks, we have not heard of any severe side effects so far from our campaign, but we realize we've only vaccinated about 2,000 kids, and we will keep you guys apprised on that as we go. We totally understand parents' concern.
And with that, I agree with Dr. Hahn. I understand that parents want to do their due diligence in research. As of now, my understanding of the data is that COVID is one of the most common viral infections associated with myocarditis. At this point, the data that I've been reviewed, the possibility of a myocarditis occurring is more likely with an infection than with the vaccine. And to be honest, I'm more afraid of the side effects. I'm more afraid of the disease than the side effects. I apologize. I have 4 kids. One of them's already vaccinated. The other 2, we've already made their appointments, or my wife is in the process of making their appointments to get them vaccinated. Like anything, there are people who react to certain ingredients, and the vaccine is no exception. But look at it this way. people react to, say, peanuts, allergies all the time, but that doesn't stop the rest of the world consuming peanuts for that matter. And in this case, the benefit of the vaccine, even in younger individuals, I do firmly believe that it's there. And hence, I do recommend that parents talk to their pediatricians and get the vaccine.
Okay, thank you, Dr. Guzman. Our next question is going to come from Ian Stevenson.
Hi, this is Ian Stevenson with the Idaho Statesman. I realize you all are not releasing much information about this report of a child's death, but I just wanted to ask two clarifying questions. So the release, it's from Health and Welfare, and it also includes Southwest District Health. Does that mean that this child resided in one of the counties in that district? And then secondly, how does Health and Welfare define the age of infants?
Great question, Ian. I can answer the first part, which is yes, the mother-baby duo did reside in Southwest District Health. And then I'm going to ask Dr. Hahn if you want to take the second half of that.
Yeah, so an infant, the way we usually use it and the way we used it here is any child under 1 year of age.
Okay, thank you.
Okay, our next question is going to come from Kevin Richert. Kevin, if you're speaking, I believe you're
no, I'm here. I was just in a different screen. This is Kevin Richert from Idaho Education News. I wanted to follow up on the rollout of the vaccine for 5 to 11-year-olds to this point. To what extent is the vaccine available through school clinics, clinics in school? Are there plans for more in-school clinics? And what are maybe the obstacles or challenges to setting up those kind of programs?
Yeah, thanks, Kevin. I'll start. We don't really have that many official school-based clinics across the state, but certainly our local public health districts are working very closely with all of their education partners across the state, with local providers to set up a wide variety of environments for giving a pediatric vaccine. For example, we just heard in eastern Idaho that they set up drive-through clinics and offering after hours, like after school hours, where people can drive through and get the vaccine. And they've done several hundred pediatric doses, as well as offered booster doses for the families. So it's offering kind of that nice environment to make it conducive for families to come through. We know that some of the primary health, for example, is making appointments. There's lots of local clinics and pediatricians' offices and family practice offices, just a wide variety. But I am going to, we do have Tamara Olson, who represents our immunization program, to maybe give a little bit more flavor for the locations and some of the rollout. Tamara?
Okay.
Thank you, Alki. The pediatric vaccine is rolling out smoothly. We were able to pre-order doses just to make sure that they all got out into the different areas of the state. All of those vaccines should be delivered by the end of day today is our expectation. And vaccine is also being delivered to many of the pharmacies across the state. So it's making its way out there. Providers are getting their systems updated, training their staffs, and I think you're going to see that vaccine in more and more places over the coming days.
So it sounds like even though there may be limited numbers of in-school clinics, access to the vaccine for 5 to 11-year-olds right now is not a problem. It's not a big problem at this point.
Right. It's just getting rolled out, and we don't anticipate having a problem or an issue with supply or getting vaccine out into all areas.
Okay. Thank you.
Okay, it looks like Andrew Bartline has his hand up again. Andrew?
My apologies. I forgot to take that down. Sorry.
Okay. Kevin, are you? Oh, okay. All right. Well, it looks like that is. Never mind. I have 2 more hands up. The next question is going to come from Audrey Dutton.
Thanks, Nikki. I am curious about co-infections of RSV and COVID, and potentially in children, co-infections of flu and coronavirus. I don't know who might be able to address that, but I'm wondering how common those co-infections are, and how many of the hospitalizations we've seen in Idaho are due to that.
Yeah, thanks, Audrey. Dr. Hahn, do you want to field that? And I don't know if Dr. Guzman has anything you'd like to add.
Yeah, I can start, and I don't know if Dr. Turner was there. I'll just say that I don't. That's a really good question. We, with the RSV season having come so early, we have been worried about that. Of course, we've got COVID, flu, and RSVs, potentially all circulating at the same time, and co-infections can occur. I'm not aware of any co-infections, but maybe Dr. Turner has heard of any. But we certainly could query the hospitals. It might be that some have just been reported that we're not aware of. I have not heard of any. Dr. Turner, have you heard of any?
I have not specifically heard of any, but we had talked just this week, Audrey, about doing a match of our RSV cases and our COVID cases to, just to kind of get a feel for things. We'd have to look at the timing to see if it happened at the same time, but I have not specifically heard of any. Okay, we'll move on to our next question, which is going to come from Ian Stevenson.
Thanks, Nikki. Director Jeppesen, you mentioned this in your opening remarks about how some hospitals are restarting procedures that were delayed due to crisis standards of care. I wondered if you all, if there's more you can say about those procedures, and if there's any way to sort of quantify how many procedures were delayed and how quickly they're getting started again. And then I'm also curious if it's known how delays in these procedures have affected the health of those patients who needed surgery or who still need surgery.
Thanks, Ian. Director?
Well, thank you, Ian. Excellent question. And again, I'll just say, if you're one of those individuals or a family member of an individual who's had a treatment delayed, my heart goes out to you, and I can only imagine how difficult that's been. I would say, Ian, I'll answer the last part first, and don't let me forget to go back to the first part. But that is the hospitals, when they've delayed surgeries and procedures, they are still doing emergency and procedures and surgeries, and surgeries that are life-threatening or surgeries that have a high risk of increasing the negative outcome. So it's not been the case that all of those have stopped. Really what's happened is those that can be delayed without a serious long-term impact or without serious risk are the ones that have been delayed. And so hopefully that means that as we get back to these surgeries, that there's not a long-term impact to those individuals. Having said that, there will be an impact. So whether that's the person who is waiting for the hip to be replaced, they're going to have an uncomfortable couple of months here as they've had to wait, or for some of those folks for other types of treatment, there may be some negative impacts that happen as the disease progresses and treatment may have been delayed. So I don't want to leave the impression that it was with no cost to the patients and their families. That certainly is the case, that there was some impact. Again, I do want to emphasize, though, that those surgeries that were highest risk, most important, needed to continue life-sustaining or have the risk of immediate or near-term impact to a patient have gone forward. And then on the second part of the first part of your question around how this is happening, it's really happening at a hospital level based on what their capacity is. And so hospitals are highly motivated to make sure that they can treat patients. They were all excited about the time when crisis standards of care can end and we can get back to normal. And so they've been working diligently as they free up even just a little bit of space or a little bit of capacity to start reaching out to those surgeries that have been delayed or those treatments that have been delayed. And they're starting with those that are the most important. So whether that be the longest or the risk has changed now because of the delay, meaning that there's a risk that there's negative outcome for the patient, or those that are the most highest risk of a long-term impact. So they're really starting with those that have the most negative potential outcome. And that's really being driven at the hospital level as they open up, as even just little slivers of capacity open up, they're looking to do that. And then the last part of your question was how many of these there. We don't actually know the exact number. We do know it's many, probably not hundreds, probably thousands of procedures that have been delayed through this time period.
Thank you, Director Jeppesen.
May I add something, Nikki, for Ian?
Oh, yes, sure, absolutely.
Thank you. So Ian, that highlights the need for the vaccine. The vast majority of those admitted at a hospital, which is partially the reason why surgeries have been canceled. Those admissions could have been prevented by the vaccine, and that just highlights the need of we need to get our vaccination rates increased so that we can decrease the number of patients being admitted to the hospital. If we keep admitting people for COVID, then surgeries will be having to be rescheduled. And even if it's a non-threatening or a non-life threatening situation, it's still an important matter for that patient. So I would encourage everybody, pregnant, non-pregnant, to get vaccinated, and that helps us, our communities as a whole. Thank you, Nikki.
Thank you, Doctor.
Thanks, Dr. Guzman. Our next question is going to come from Anna Azalian.
Hi, Anna Azalian with Idaho News 6. I know last year and this year there was concern about flu season and the impact that that could have on health systems along with COVID-19. Just wondering how that is looking so far in Idaho.
Great, thanks, Anna. Certainly we have started to see flu in the state of Idaho, and I know that's something that is close to Dr. Hahn and Dr. Turner's hearts here and what they track. So Dr. Turner, do you want to take that first?
Yeah, I'll start and then Dr. Hahn can jump in. You know, so far the season has started off a little slowly, but we are expecting because people are not adhering to some of the prevention measures as much as they were last winter, that we could see an impact of influenza infections on our hospital and clinic capacity. And I'll defer to Dr. Hahn if she has any other comments on that.
Yeah, I'd agree. We have had some positive flu, so we know it's here. It has not taken off yet. I always remind everyone our peak flu month is usually February. So we all start thinking about flu early, which is great. We should be, because we should be thinking about vaccination and staying home when we're sick and all those things. But really, it's too early to say what the flu season is going to look like. But we're concerned for a couple of reasons. One that Dr. Turner just mentioned is that we know people are, less adhering this fall compared to last fall to some of the social distancing guidance and recommendations. And also we're worried because fewer people got infected with flu last season. So we're worried we have a particularly vulnerable, immunity to flu, as we know, doesn't last very long. Even natural immunity to flu, people can get influenza infections repeatedly. So we are worried that we have kind of this susceptible population out there, and that it could be quite severe for some people, but too early to call for sure.
All right, our next question is going to come from Melissa Davlin.
Thanks, Nikki. This question is for Director Jeppesen. Understanding that this conversation is probably more political and about business than about medicine, I was wondering if there's been any dialogue between the department and lawmakers ahead of next week's session, where lawmakers will likely consider COVID-19 vaccine mandates among employers.
Director, that's all yours.
Well, thank you, Melissa. Thank you, Elke, I guess, for that in my way. Our role as an executive agency in the legislative process is to provide information to the policymakers, the legislators, so that they can then make policy, pass legislation, and do appropriations. And so we stand ready, as always, to provide the best information we have on any of the topics that we are, including COVID and the pandemic response and vaccines, for any lawmaker that wishes us to provide information on that. I would say to date, I've not had any outreach from legislators ahead of this specific session for topics in this session.
Thank you.
Okay, I'm going to do a quick scroll here before I commit. Nobody else has their hands up, so not seeing any more questions for today. We'll go ahead and wrap it up. We are planning another media briefing at 2:30 p.m. next Tuesday. Thank you for joining us today.